In this episode of EHA Unplugged, we will revisit a spotlight talk from EHA2024. Professor Thorsten Zenz from the University Hospital in Zurich discusses current approaches to the treatment of relapsed hairy cell leukemia.
So my name is Thorsten Zenz. I work in Zurich, and my task is to discuss relapse treatment of hairy cell. So I'm only going to speak about classical hairy cell leukemia. So this is BRAF mutant classical hairy cell. You will be aware that there's a lot of discussions ongoing with the new classifications, but I think for the content of this talk, we'll make it simple. So we're only talking on classical hairy cell. So the first part is really going to be a personal topic. I'm going to tell you the story how I got engaged in hairy cell leukemia. So hairy cell is a very rare lymphoma. Patients usually present with cytopenia, large spleen, and then if someone actually does the marrow, the diagnosis is really very straightforward. When Enrico Tiacci found that classical hairy cell, these patients always have the BRAF V600E, I got interested because the BRAF V600E is a classic precision oncology target. We have drugs that we can inhibit, and when you think about the 100%, now that's very likely that hairy cell depends on active BRAF signaling. So that's how I kind of from the precision oncology angle got interested. And this is linked to a patient that I saw many years ago in Heidelberg, and this is the history which allows us to revisit how we treat classical hairy cell. So this particular patient was treated somewhere else with cladribine and didn't respond. Then he was, according to guidelines, that didn't work, and he got pentostatin, which is reasonable because there was a two-year period, and then he was actually referred to our center here also to consider, should we do a transplant? I said, okay, let's just add the antibody and maybe this will help. But in this particular patient, that didn't lead to a remission. So, and this is very unusual, a very unusual case. And this was in 2012. And the report had just come out that all these patients have a BRAF mutation. So when we could get our hand on a BRAF inhibitor, we put the patient on a BRAF inhibitor, and very quickly counts go up. And I'm sure some of you have used a BRAF inhibitor in hairy cell. It's phenomenal. I mean, it's just phenomenal how quickly this works. So when trying to get the drug, I looked up the initial melanoma trial. And for someone not from the field, I couldn't see any difference in response regardless of dose, right? So I chose the lowest dose. After 14 days, you could clearly see that the disease disappears, and then it took about a month to get a complete remission. And I was trying to get a deeper remission, so I increased the dose of the vemurafenib, but still to this date, I've not been able to extract a dose response. It's probably somewhere between the low dose and the melanoma dose. We use some of the immunohistochemistry studies to look at what's actually happening. The marrow is full of mutant cells. And then you can also measure the pathway activity by looking at phospho-ERK in immunohistochemistry. And the tunnel assay shows you a number of dead cells, which there aren't any in the beginning. And then we gave 6 days of treatment, and this massively changes the pattern. You still have a lot of tumor cells, but with the inhibitor, none of them have active signaling, and this leads to apoptosis. So this is a clear demonstration of oncogene dependence, and the cells may react in different ways. They may just sit there and not do anything, but here the cells depend on it. They die if you remove BRAF signaling. We then started to treat more and more patients and have now nicer images of this phospho-ERK signaling, but we also saw that in only a proportion of patients, you will actually be able to remove all the cells. Enrico Tiacci says it's the microenvironment. I would say, I don't know what it is, something in addition. So this already alludes to what should we be doing clinically. The BRAF inhibitor itself is not gonna do the trick for all patients. So to conclude this, it's clear hairy cell is addicted to active signaling. The BRAF inhibitors work phenomenally. If you have patients who are sick from infections, any problems, just start with the BRAF inhibitor and then take care of the disease later. So there are some situations where BRAF inhibitors are standard of care. We also saw side effects, like all the side effects at the lowest dose: skin problems, arthralgia, kind of inflammatory reactions. So I still think that some of the hairy cell experience may also have affect dosing, or has the potential to affect dosing in other cancers. While we were starting to treat patients off trials, obviously, both in the US and in Italy, you guys had set up the trial and enrolled patients. And the results are published in the New England Journal. So the trial showed very similar results. About a third of patients will get a complete remission. Most patients respond. It takes a few weeks. Usually platelets come up first, and then the rest of the counts improve. Because of the toxicity of the BRAF inhibitors, you need to stop treatment, right? For a disease that doesn't impair survival for the vast majority of patients, you cannot continue a BRAF inhibitor because of the side effect profile. So Enrico's group has combined vemurafenib with rituximab, CD20 antibody, and this is what we currently do. So when we treat patients, we usually start with vemurafenib, but try to get to a complete remission by combination with rituximab. So I think one of the topics to discuss, when should we use this regimen over repeating purine analogs? So there are so many great drugs in B-cell lymphoma, so the temptation is to use the BTK inhibitor, the venetoclax, all the other drugs. So ibrutinib has been tried in this trial, which included classical as well as hairy cell variants. Quite a few patients actually still on treatment. So my take home is, if it works, it's good, but it's only a small fraction of patients where this works. You will get complete remission in about 40% of patients, but you need to hold your breath. You need to keep them on treatment for a while. So this, like, to me, this is clearly an active drug. I have not used it very much because all the other things work so well. So it really depends on what you have access to. So I'm already heading towards the end. All those different treatment options, they're hugely confusing anyway. So a lot of times it's about access to drugs. So there's the moxetumomab, which in Europe, we don't have access to. So we've been able to put patients on the trial, and it's clearly an active drug. You can also see if your patient can go to the NCI. I think they may still have access. But other than that, it's really the questions we usually ask ourselves are, should I reuse a purine analog? And there, the depth of remission first time round and the length of duration of remission is a topic. Also the age of the patient. If you have someone who's 79, you don't necessarily have to worry about long-term effects as much as if you have someone who's very young. And then the question, how do they present in relapse? Do you have time to kind of get organized, or is there an infection which would always argue for a BRAF inhibitor? And I mentioned that most of the time we now use vemurafenib and CD20 antibody if we don't want to go back to a purine analog. And then that's kind of the scenario we use. So there are different guidelines. I think the Hairy Cell Consortium is coming up with a new guideline. There's also going to be an EHA guideline. And these guidelines are always interesting to write in the absence of a lot of data. So, but I'm involved in the international guidelines, like only in a minor way, but I'm also involved in the German guidelines. But I specifically pulled out the French guidelines because I don't think I agree with the concept that if you have someone that you put on a purine analog without rituximab, for example, and they respond well for 2 years, you go back to a purine analog. It just seems like a very short period of time. So you can go to purine analog and an antibody, hoping that this will now be phenomenal. which is a realistic scenario, but the trajectory of just repeating purine analogs doesn't appeal to me. So what the French group have done is they've suggested if it's more than 5 years, give it another shot. But they've also put rituximab plus purine analog. So my interpretation of the field is, in first line, if you were a patient, you would want to have purine analog and CD20 antibody. But somehow in the physician community, people have not taken up, because there's, in a lot of places, because there hasn't been the randomized big trial to show, but all the data suggests that it's just so much more effective. And in terms of the side effect profile, I mean, we use these combinations all the time. There have been all these big FCR trials that we shouldn't be afraid. So my prediction is more people will use combinations because it's clearly more active. Yes, you can get away with just the purine analog, and for the vast majority of patients, it won't make a huge difference. But if we now focus on relapse, you really need to look at how did patients respond. So I continue to do marrows on young patients after 6 months, because I want to know, did they get a complete remission, right? It's something else if you have a lot of cells in the marrow that just sit there. So I usually recommend for younger patients to have the marrow, and most patients will accept this. Let's discuss the question on how, like, after how many years of response would you go back to a purine analog? To me, it's a function of age, function of response, and I like the 5 years, right? With hairy cell, in contrast to many of the other lymphomas, very hard to predict how that second round will, like, sometimes you see longer response with the second round. So maybe there's a cumulative effect on the DNA that further paralyzes these cells. I'm not sure I've been very tempted to do that second round of purine analog at 6 months. If you have patients with your primary refractory, which is exceedingly rare, or patients with a short response, often, if they relapse within 2 years, I will for sure go for rituximab and vemurafenib. But even there, I expect patients to relapse. I mean, some of the responses are so deep that it really seems to be an excellent regimen. There's a basket trial looking at MEK and BRAF inhibition, which shows very, very good response, probably more CRs than with just the BRAF inhibitors. I haven't been able to use it outside of a trial. Because of the vastly different mechanisms of action, I would be tempted to continue to use BRAF inhibitor with CD20 antibody. And then in later lines, there's people, to big centers, people continue to get referred with the question of allotransplant. I've never sent a patient to transplant. I think there's some trials with CAR T. I don't know if that's something that you have access to, but it's really exceptionally rare, because what we haven't mentioned here is that you put someone on a BRAF inhibitor and a CD20 antibody, and then they respond, and you stop after 3 months. And then they come back, in a year or 2 or 3, and then they can be re-exposed. So I think the question of sequencing of different treatments may not be so very relevant. But I do want to raise your attention to this question of, should you just go back to cladribine because it was easy to apply after 2 or 3 years? I really prefer this kind of 5-year interval, because there are all these other treatments that are available.
I think vemurafenib and rituximab is an excellent salvage regimen, but with the follow-up of our trial, it's clear that there is a small subset of patients that are at 5 or 6 years is free from relapse, but many patients still relapse. Yeah. In the trial, they had a median of 3 prior lines of therapy, and it's clear that for, I would say, the majority of patients after so many lines of therapy, this is not a curative regimen. And so I think that upon relapse after vemurafenib plus rituximab, one can repeat it if the duration of response was nice, but otherwise other options should be pursued, like BTK inhibitors or even venetoclax. We had a relatively good experience in patients, in a small number of patients relapsed after vemurafenib plus rituximab. Venetoclax was able alone or with rituximab to reinduce remission, although it took quite a while to recovery of cytopenias like with ibrutinib. And so I think it's very difficult to eradicate this disease long term. Perhaps with cladribine plus rituximab upfront, maybe we will see with the long term outcome of the and follow up of the trials that have been done. Perhaps we will have like decades-long remissions that will translate into a functional cure.
I don't think we need to eradicate the disease, right? We need to get to complete remission for a long period, and we need to be careful with side effects. We need to be very careful with infections. We had a young patient dying from, he had tuberculosis and hemophagocytic syndrome and COVID. I think that most of the attention should be, do not batter your patients too often with furin analogs, take advantage of some of the other agents, but it's all around supportive care. Also patients who present with infections where people are maybe hesitant to do something. I think the BRAF inhibitors are really a huge advantage.
A comment about repeating cladribine. One of my observations, I'm not sure how reproducible it is, that often the degree of marrow hypocellularity and stem cell compromise is very significant at relapse with even moderate hairy cell infiltrate. Yeah. So I'm very hesitant to repeat cladribine exposure where you've got ongoing impaired stem cell reserve. So I would then tend to use a BRAF inhibitor. We have dabrafenib rather than vemurafenib. I think a dozen patients, dabrafenib with rituximab. Okay. I think 9 out of 12 responders, those sorts of numbers. Yeah. Can you comment on any mutational profile or escape mutants when they do become BRAF inhibitor resistant? So
there's work from the UK that RAS mutations can occur, but it is rare. These mutations occur if you're doing continuous treatment. If you'd only do a few months, but usually it's the RAS activation